Hi, I'm Annabelle, and I'm going to be discussing post-operative pain assessment and management, its importance, the current barriers to effective pain assessment and management, and possible strategies to overcome these. Pain is an individualized experience that affects one's physical and emotional state. It is a highly subjective thing that can be influenced by previous experiences, current mental state, and more, and ultimately allows the body to react and attempt to heal the source of pain. Pain management, particularly post-operative, is important for many reasons. Pain management or relief is a fundamental right of care for patients, and it is essential that nurses and other health professionals provide this right to their patients. Post-operative pain can also lead to prolonged hospital stays, increasing the cost of a patient's care. Prolonged opioid use that could possibly lead to addiction and other adverse effects, and can possibly eventuate from acute pain, which is less than 3 months of continuous pain, to chronic pain, which is ongoing pain that becomes much harder to treat. Pain also encourages immobility for patients, increasing their likeliness of developing complications such as DVT. The psychological and emotional impact of pain should also be considered, as this can have a drastic effect on a patient. So, what actually is the problem? Well, nearly 86% of patients undergoing surgery report post-operative pain, 50 to 75% of which report this ongoing pain as moderate to severe, which is undoubtedly too high. Considering the amounts of surgeries are inevitably increasing, it is likely so will the amount of people experiencing post-operative pain. The current best practice procedures for pain assessment outlines pain assessment as a holistic and multidimensional approach, and it is important for health practitioners to acknowledge that pain is an ever-changing physical and emotional experience that should not only be monitored by health professionals but by the patient themselves as a team effort. Currently, pain assessments used in the clinical setting include the numerical rating scale, in which the patient rates their pain from 0, no pain, to 10, the worst imaginable pain for the patient. And this can be used to identify the severity of pain management needed for the patient. This can also be used in conjunction with the PQRST pain assessment that assists health professionals in determining the severity and degree of pain. These assessments may need to be altered for patients that are unable to communicate effectively with staff, such as pediatric, non-English speaking background, non-verbal, or cognitively impaired patients. These include the Wong-Baker Faces Pain Scale, in which patients can point at a face they identify with that demonstrates different levels of pain, or an independent assessment of patient's body language undertaken by the health professional. In this, the staff member would look for behaviours such as fidgeting, rigidity, restricted movements, and the mobility of a patient and compare this to their baseline to assess their level of pain. Despite these current best practice recommendations, there are still barriers to post-operative pain assessment. Patients may feel as if there is a sense of embarrassment, or they may be being judged by staff when reporting pain. This stigma is ineffective in the treatment of patients and can lead to serious health consequences. Inaccurate assessment tools or a lack of pain assessment resources are also significant barriers to pain assessment, as this could prevent pain from being effectively and appropriately reported and managed, further leading to serious consequences on a patient's pain level and overall health and recovery. Strategies to overcome these barriers include educating a patient on the importance of reporting pain and how this should not be a shameful or embarrassing action. Educating nurses on the subjectivity and relevance of pain assessment, as well as the consequences that stigma surrounding post-operative pain can have, is another strategy to improve assessment. Finally, standardizing guidelines and policies of pain assessment across multiple hospitals, health districts, and even states can help to prevent oversights in assessments and regulate the assessments and actions being performed by nurses and other health professionals. The current best practice strategies for pain management relies on communication between staff, such as nursing handovers and interdisciplinary communication, as well as appropriately documenting pain management plans and actions. Pain management is currently best undertaken when pre-operative education and planning is performed with the patient, including informing the patient of treatment options, establishing the patient and treating team's goals for recovery, and assessing the patient's medical history. For example, have they had previous experiences of severe, untreated post-operative pain? Non-pharmacological management strategies are also essential, such as positioning of the patient, teaching the patient on breathing strategies and its importance, and the significance of reassurance for the patient, all of which can have a significant difference for the patient and their pain levels. Pharmacological management is also currently used and essential in pain management, particularly for patients with severe pain. These options include the use of opioids, non-steroidal anti-inflammatory drugs, and extended-release analgesics. all of which involve continuous monitoring and observations of a patient for adverse effects, and the impact these strategies may be having on the patient's pain levels. Similarly to pain assessment strategies, the current best practice guidelines of pain management also have their limitations. A lack of interdisciplinary communication, in which the communication between disciplines is flawed and other disciplines are forced to only gain knowledge from patient notes and not contemporaneously, leads to possible missed information or information being communicated later than it should. These barriers are furthered by possible nursing handover faults, in which the pain management plan and actions undertaken by the nurse may not be effectively explained during handover, leading to possible management actions being missed, repeated, or done incorrectly. Finally, a lack of nursing education on basic non-pharmacological pain management can lead to inappropriate care of patients, and actions such as repositioning or reassuring a patient may be missed. Despite these barriers, there are strategies that can be undertaken to improve post-operative pain management. This includes a standardised nursing handover framework that is enforced throughout multiple hospitals and health districts, such as ISBA. Encouraging positive interdisciplinary communication between all disciplines involved in the patient's care, and providing opportunities such as meetings for these interactions to take place. And ultimately, educating nurses on the importance of effective post-operative pain management and communication with other staff and the patient. All of these strategies, paired with the strategies to improve post-operative pain assessment, are effective in promoting patient recovery and lowering the severity and amount of pain a patient is ultimately experiencing.